Picture this. You're on shift in a packed clinic, right? And a patient walks in, literally clutching her head, just in sheer agony. The waiting room is overflowing, the clock is ticking, and you've got to make a rapid, accurate diagnosis. So is this just your run-of-the-mill headache, a severe migraine, or is it something life-threatening?
You grab her chart, it's a 35-year-old female presenting with this intense, unilateral throbbing headache. The lights in the exam room are completely bothering her, which is classic photophobia, and she's actually already vomited twice. Look, clinical stakes like this are exactly why having a rock-solid, structured diagnostic tool is absolutely crucial.
Salam! Welcome to a little push, 5 minutes medical mnemonics. In this explainer, we're diving straight into one of the most high-yield concepts in neurology and primary care. We're going to give you the exact tools to confidently lock down a migraine diagnosis and, just as importantly, spot when real danger is lurking.
Section 1. The Pound Breakdown. Diagnostic Criteria.
Okay, so the ultimate board favorite mnemonic to organize the 5 cardinal features of a migraine is POUND. Hit 4 or 5 of these and your probability of a migraine is, well, incredibly high. So starting it off, P is for pulsatile. Your patients usually aren't going to describe a tight band squeezing their head. Instead, they'll describe this distinct throbbing or pounding sensation that actually matches the rhythm of their pulse.
Moving right along, O is for 1-day duration. Now, the specific time frame here is key. An untreated migraine classically lasts anywhere between 4 and 72 hours. If it's shorter than that, or if it's dragging on constantly for weeks, you know you need to broaden that differential.
Next up, U stands for unilateral. So while tension headaches are typically described as bilateral, kind of squeezing around the whole head, a classic migraine usually zeroes right in and involves just one side of the head.
Then we have N for nausea. You know, migraines are rarely just about head pain. They're frequently accompanied by pretty severe autonomic symptoms, primarily nausea, which often escalates to active vomiting right in the middle of the episode.
And finally, D is for disabling. The intensity of this pain isn't something the patient can just, pop an aspirin for and ignore while going about their day. It's severe enough to completely sideline them and interfere with their daily activities. So, quick recap. Pulsatile, 1 day, unilateral, nausea, disabling. Hit 4 or 5 of those and you are squarely in migraine territory.
Section 2. High-yield clinical correlations, testable secrets.
Now that we've got the diagnosis locked down, let's talk about those testable secrets that examiners just love to weave into vignettes. Our first secret is the aura clue. Check this out. About 1/3 of migraine patients experience a prodrome, an aura, that typically kicks off 5 to 30 minutes before the actual headache hits. You really want to keep an eye out for visual disturbances here, like scintillating scotoma, which are those blurred areas surrounded by moving zigzag lines, or even unilateral weakness.
Another huge thing is identifying what actually sets the headache off. Examiners love, and I mean love, hiding common triggers in a patient's history. So watch out for hormonal shifts, like menstruation, environmental factors like high stress or just being super hungry, and very specific dietary clues. The big ones? Chocolate, cheese, and red wine.
When we're talking treatment, you've got to clearly divide your strategy. For an acute, active attack, you want abortive therapy, so think triptans or NSAIDs. But if the attacks are happening frequently and they're super disabling, you shift to prophylaxis to prevent them from happening in the first place. The board favorites for prevention are beta blockers like propranolol or meds like amitriptyline and topiramate.
Section 3. Headache red flags. Seeking serious causes.
While primary headaches like migraines are super common, we've always got to stay vigilant for secondary headaches that hint at a much more serious underlying cause. To make sure you literally never miss a dangerous diagnosis, anchor this catchy submnemonic in your mind right now. First, worst, cursed. Whenever a headache fits one of these categories, your clinical alarm should be ringing loud and clear.
Let's break that down real quick. First means it's the patient's first ever severe headache, which means we have zero established history to rely on. Worst refers to the classic quote, "worst headache of my life." That's often the sudden thunderclap onset, which is a massive red flag for a life-threatening subarachnoid hemorrhage. And cursed? That means there's a sudden change in their normal headache pattern, or maybe it's a new onset headache in a patient over the age of 50. That immediately requires you to rule out things like temporal arteritis or mass lesions.
Section 4. Rapid Review Quiz.
All right, it's time to test your active recall. I'll ask a question, and I'm going to give you a few seconds to think it over before the big reveal. Here's question 1. Which drug class is a board favorite for migraine prophylaxis, often used when attacks occur frequently? Take a few seconds. 3, 2, 1.
And the answer is beta blockers, specifically propranolol. Remember, you can also use amitriptyline or topiramate for preventative care too.
All right, moving to question 2. If a patient describes the sudden onset of the worst headache of their life, what life-threatening condition must you urgently suspect? I'll give you a few seconds here. 3, 2, 1. The answer is subarachnoid hemorrhage, or SAH. Seriously, never ever ignore the worst component of our red flag mnemonic.
Section 5. Final takeaways.
By mastering the pound mnemonic, identifying auras and triggers, and never ignoring those first, worst, cursed red flags, you are well on your way to much sharper clinical assessments. Keep pounding those books. But before you go, ask yourself, how many times have you or a colleague maybe dismissed a severe headache that could have actually been a critical warning sign? It's something to think about. If you found this explainer helpful, please hit that subscribe button for more from A Little Push. We love learning with you, and building this connection means everything to us. Until next time, salam.